You guys are going to, because this is really changing gears and looking at cancer from a different perspective, and that is biomarker. We all understand what biomarkers are, right? Something which tells us about something, right? But you will be surprised how many different kinds of biomarkers are there and how useful they are. Okay, so I could not find one slide which had all the biomarkers, because some people put these biomarkers, some are common, some add more, but then these are missing. So I put different pictures there, okay? And I will tell you about all of them. So I will tell you what is coming, because you guys don't even know what is coming. Okay, so lecture 9 is completely based on what are the different kinds of biomarkers and how they are used. Okay, then lecture 10 is about health disparity. Okay, if I ask you health disparity, if you have to explain that, what does it mean to you? Because I certainly did not understand what it meant. I did not understand the full extent of what that meant. So can anyone of you can explain what is health disparity?
Impairment with other, like dysregulation.
No. So health disparity, I will tell you. Before I put together this, I'm more experienced than you guys, but even I did not understand the extent of health disparity. So my understanding of health disparity was that in US there are white Caucasian population, and that there is a African American population. So originally they came from Africa, and they are Americans too, right? So they have been living in the same country for generations and generations and generations and generations. But they have if these guys will have HER2 positive breast cancer, these will have TNBC, triple negative breast cancer. They have the same thing. These people will die. They will not survive. They will survive. Like, there is a lot of disparity between them. So my definition of health disparity is, because funding agencies give a lot of money to study health disparity. Why people of this descent are more receptive, of this descent are not receptive, right? So here we don't have that much diversity, but in US there is huge diversity, because of many different countries. Like Asian population, they show some phenotype, but Caucasian will show something and African will show something. So people have very different response. Okay, some people will have the worst kind of cancer, same prostate cancer, but the worst cancer. But these guys will not have that kind of cancer. So my understanding, that is health disparity. That is definitely health disparity, but that is the only thing I knew about that. So we'll discuss in the next lecture what exactly is health disparity. And then in the last lecture of today, we'll come back to explain that how you can use biomarkers to identify and fix the health disparity. So that's how the whole structure is arranged. So let's start with biomarkers there. Okay, so as you can see, there are many different biomarkers. So what is a biomarker? Biomarkers are measurable so biomarker could be anything which tells you about the state of a system, that is a biomarker. It could be a DNA, like it says here. It could be a molecule, like a metabolite. It could be a gene, protein, imaging feature that provides valuable information about health and disease. Okay, so it could be a receptor which is expressed. In some cases, that is a biomarker, like HER2 positive. HER2 is a biomarker because it is telling you it is HER2 positive cancer, right? If, like prostate cancer, PSMA is a protein which is expressed at high level, that is a biomarker, right? So this is a normal individual with normal biomarker, but see, here it is expressed in huge amount. So now it becomes a biomarker, all right? So how do you find, so biomarker can be a DNA, it could be a RNA, it could be a protein, it could be a metabolite. And so how do you find it about DNA? So suppose my DNA is different, some part of my DNA is different from, I don't even want to say my, because I don't want to even associate my disease, me to disease or you to disease. So we'll talk in abstract terms, okay? A and B, normal and unhealthy. So how do you figure out if the problem is at the DNA state, right? So DNA is, some DNA has changed in this one, which is leading to disease. So now we have to profile the DNA, because if we look at the RNA, it's not going to help. We have to profile at the DNA. Many times DNA is perfect, same. This is the diseased guy, this is the normal guy. DNA is exactly the same. The protein is the problem. Okay, even if you have the same DNA, the protein can be different. So if you have to figure out, now if you are doing DNA profiling, it's not going to help. Now you have to do proteomics, right? So that is why if you have to do RNA, you do microarrays. So for DNA, you use FISH, F-I-S-H technique. For RNA, you use microarray or gene chip. For proteins, you use proteomics. For metabolites, you use metabolomics. Okay, so that is what they are showing, that you have to use different techniques to find out at what, where is the problem, what is the biomarker which is different between normal and disease state. Okay, so this is FISH technique, in just in case you don't know. So you take the DNA from normal and diseased patient, you separate the two strands together. Many of you have done PCR, denaturing, heat it up, as simple as that. And then once you denature it, you label them with probes, and then so these probes are denatured, and then you take a known sequence of DNA and see if that probe binds there, and that will tell you whether it is binding or not binding, and that is how you can discover the abnormality in DNA. Okay, so this is that thing, and this is chip. So anyone knows how RNA chips work? No. So I will tell you the story during the break about RNA chip, how it was discovered. It is a very interesting thing. Like 5 real smart people sit together and how this technology came together. So I know the inside story, because one of the person who developed this chip was the director of the institute where I worked. Okay, so so what you do is that this is normal, this is diseased. So you take out the tissue, the biopsy tissue, normal tissue, normal prostate, diseased prostate. Okay, and then you make the RNA out of that, so which is a very easy thing. You make the RNA from this one, RNA from this one. The RNA from this one, you color it green. RNA from this one, you color it red. So you're not literally coloring it, you're attaching a probe which will give red fluorescence versus green fluorescence. All of these are piece of cake. Okay, and then you make a chip where DNA sequences are there, small DNA sequences. So suppose you want to check 20 genes, suppose you want to check 100 genes, suppose you want to check 200 genes, suppose you want to check 5,000 genes. So you make a DNA chip and you will have unique sequences, 20 mer sequences of those unique genes. So for example, if you're comparing gene 1 to gene 2, even if they're close, something will be unique about gene 1 versus gene 2. So you always use unique sequences, because you're not using the whole gene, you're using just a small piece. So that small piece should be enough to tell you this is for that gene, this is for that gene. So you have a chip which has the DNA sequence there for all different genes, small pieces in each well. Makes sense? Now you add the RNA. RNA and DNA will hybridize if there is exact complementary. So DNA sequences are the complementary sequences. RNA, if it binds, signal will light up. If it doesn't bind, signal will not light up. Are you guys with me here? And then you compare. So here what they have done, they have mixed it together. So they took normal cells, disease cells. They mix the RNA together. One is green, one is red, correct? Then they add the mixture to the chip. So if both binds green and red, the color will be yellow. If only green binds, it will be green. If only red binds, it will be red. So now look at this thing. Pathological cells are red. Green are normal cells, and yellow when both are present. So there is one chip which will tell you these genes are okay because they are expressed in all. Yellow ones are good, both are having. Green ones are only present in normal cells. That means red cells don't have that RNA. Bad news. And then red cells have something which even normal cells don't have. That too is bad news. So one chip has given you so much information, right? That is gene chip. Okay? Very simple, right? Okay. I will tell you a story about gene chip in our lab also. Not in my lab, but when I was a student in that lab. That was before this was discovered. Okay? We were playing a game, and there was an undergraduate in our lab, okay, maybe 17, 18 years old. She suggested this method. Okay, and that time nobody had ever done the green color and the red color. And she said, you make one green, one red, you mix them together. And I remember I was laughing because I said, how can you make it one red and one green? Because I could not think that you could use a probe. But she said, if you could make one red, one green and mix them together, this will work like that. So this idea came from an undergraduate. So the point here is that think wild. If you can think it, you can do it, you know. Okay, so biomarkers now we know can be DNA based, could be protein based, could be also lipid based, because you know lipids are very important. It can be sugar based. We are not talking about glycosylation in this course. Have you guys heard of glycosylation, right? So all the many proteins in the cell, they are glycosylated. And glycosylation pattern differs between normal cells and pathological cells. So you can even find what kind of pattern is present, and that could also be a biomarker, okay? And you can do tons and tons and tons of things with the biomarkers. You can identify exactly what kind of cancer it is, okay? HER2 positive, HER2 negative, triple positive, right? You can monitor the disease progression. You can monitor whether it is getting better, whether it is getting worse. You can tell how severe it is or how benign it is. You can do screening of drugs. You can predict treatment response. You can predict what drug you should give, and we'll come to all of this in just a minute. So these are some of the types of biomarkers like predictive, prognostic, diagnostic. Let's go one by one. Okay, so this slide I just put this morning here because this was not supposed to be there, but you know, I thought that if I tell you about this biomarker, then this biomarker, after 2 or 3 or 4, you will get all mixed up. So I thought I will start with the differences, then I will go over it, and then we'll again come to the differences so that you really understand the difference, because sometimes it seems they're overlapping with each other, okay? So look at some of the biomarkers here. Some of them are very easy to follow. So the risk is that, what is the meaning of risk biomarkers? So all of us are normal people, thankfully, on this day. But who is more prone to develop some sort of cancer? That is the risk biomarker. Disease is not yet there. We are just predicting that is there a possibility that somebody might develop develop a disease. So who is likely to develop a disease? Is it dependent on treatment? No, the disease is not even here, so there is no treatment there, right? So this is before disease. So then we can do prevention screening. A very good examples are that, you know, women, they undergo mammography. It is a must thing to do every year in US because, you know, so many people's life have been saved because, and the insurance company do not charge for that. If you charge for it, half of the people are not going to get it done. So they make sure that is free once a year, okay? And so numerous people have been saved by that one. because when there is no disease indication, but it is a possible risk there, especially for women after 40 years old. Okay. Okay, diagnostic. Does the patient have the disease? Okay, so sometimes there is a pain in the stomach and we don't even know whether it is just a simple pain because we ate something or is something serious. So diagnosis is that we have to find out if the disease is there or not. That is diagnosis, right? We know the meaning of diagnosis. Treatment dependent? No, because we are just diagnosing the disease. Okay, so we are suspicious that because the stomach is hurting, is there a disease, and we are diagnosing it. So this is basically disease detection. Okay, prognostic. Prognostic is that, this guy has triple negative breast cancer. Oh, that is very severe. That's a very bad news. Oh, this guy has HER2 positive. No problem. This can be treated. So we are predicting the future here. We are prognosis. Pancreatic cancer prognosis is extremely bad every time. Breast cancer, not at all bad. Testicular cancer, somebody said to me, somebody has to have the cancer. They are forced to have testicular cancer because it's just so easy to repair. There is another cancer, somebody was telling me 2 days ago, I don't know who was telling me, and they said that is the best cancer to have because it's 100% treatable kind of thing. So we are giving prognosis, right? This is bad, this is good, this is... Cancer is bad, obviously, but different cancer have different kinds of prognosis. That's what prognosis means. How the disease will behave. Treatment? No, we are just telling pancreatic cancer is bad, right? So no. So this is after diagnosis. We are predicting the outcome. Okay. Predictive. When you say predictive, it is different from prognostic because now we say, okay, this is HER2 dependent cancer and we are going to give Herceptin. So we are predicting, yeah, it will work because it's HER2 positive, Herceptin should work. So it is predictive biomarker. So this is we are planning before therapy. We are selecting it for treatment based on what is wrong there. Pharmacodynamic, okay, this is very important one. So what happens is that you have given the therapy, but then you are monitoring, is it really hitting the target, is it going down? That is pharmacodynamic. We'll spend a lot of time on this biomarker. Okay, and then therapeutic, what is the drug's molecular target? To find the exact mechanism of action, again I will tell you the details about that, and there are even more. Okay, so risk biomarker indicates susceptibility. They are used in healthy individuals. BRCA1, BRCA2, Angelina Jolie, no cancer. She got she got all the surgery so that she never has those cancer. So it does not diagnose disease. It is just telling you that these people are at risk of breast cancer. Diagnostic biomarker. You actually say whether the disease is present or not present. We are diagnosing the disease. Okay. What is the advantage? Aid in early detection of the disease. Most of the cancer, if you can detect it early, you can treat them. Pancreatic cancer is so lethal because you cannot detect it in stage 1, stage 2, stage 3. It can only be detected in stage 4. And by that time, it is too late. Okay. So for prostate cancer, people do PSA test. For breast cancer, they do HER2 test. Okay. So this is diagnosis. This is just telling you some more diagnostic. So prostate cancer also has BRCA2 deletion. Colorectal cancers have KRAS mutation, EGFR mutation. So all different cancers have different kinds of markers, and you can use that to diagnose what kind of cancer it is. Obviously, if it is in the colorectal region, it is colorectal cancer, but that is not enough. Just knowing one thing is not enough, so you can tell exactly what kind of cancer it is. Prognostic marker, I told you in the very first class, tumor stage, TNM staging. More zeros, better it is. Higher the number, bad it is. That's prognosis. Higher number, oh, it has reached lymph nodes, poor prognosis. It has not reached lymph nodes, good prognosis. No metastasis, good. Metastasis, as bad as it gets, right? That is all prognosis. Okay, how aggressive it is. Predictive biomarkers, now we are coming to therapy. So predictive biomarkers will say treatment, predict response to a specific therapy. For example, if you look here, EGFR is mutated in, this cancer here, and also EGFR, this one, colorectal cancer, right? So if it is EGFR, so you can predict what kind of therapy one should be given for EGFR. Obviously, we have to target EGFR, so we will use EGFR inhibitors. If it is HER2, this is another name for Herceptin, right? So Herceptin, if it is PD-L1, immunotherapy. So this is the question, which drug should I use? That is predictive biomarker, okay? So this is more about predictive biomarker. So EGFR mutations in lung cancer.
Time is 10:30.
10:30. Okay, can I just finish this slide?
Sure.
Thank you. Yeah. So I'll stop at this slide. Okay. So predictive biomarker will tell us exactly based on what kind of like if HER2 is amplified, we will use Herceptin. BRCA1, we will use PARP inhibitors, right? So that plays a role in patient selection and precision oncology, and you could give precise drug to that patient. I will stop here, okay? Okay, so now we come to predictive biomarkers. Oh, I already told you about predictive biomarkers. So the next one is therapeutic biomarker. Okay, just 1 minute. Okay, so therapeutic biomarker tells you about the mechanism of action. So what it tells you, what is the drug targeting? So for example, for Imatinib, right, Gleevec, this is another name of Imatinib, it is targeting BCL-ABL. Nivolumab is targeting PD-1. Okay, so therapeutic biomarker tells you about the molecular target of the drug itself. That pharmacodynamic biomarkers are extremely important. Okay, they monitor how the drug is behaving in the body. Okay, so that markers measured biological changes induced by the drug. Okay, whether the drug hit its target and produced its intended biological effect. So it confirms the mechanism of action, validate target engagement, and that also tells you what dose you should use. So in tomorrow's lecture, we will talk about the dose in great details. Okay, so for example, if you give HDAC inhibitors, so if you give HDAC inhibitors, acetylation should increase or decrease. HDACs are the one which remove acetyl group. So if you are inhibiting HDAC, acetylation should increase. So we are giving a patient HDAC inhibitor, and then what we will do? We'll check if the acetylation levels are increasing. If it is increasing, you know the drug is hitting the HDAC, right? So similarly, if you are giving angiogenesis inhibitor, that is anti-VEGF drugs, because VEGF increases angiogenesis, then you will look at VEGF signaling, right? So those will be pharmacodynamic biomarker. In simple word, it shows what this drug is doing to the body. Okay, so this pharmacodynamic biomarkers, in abbreviated form, they are called PD markers. They are very important in drug development. So that confirms the mechanism of action, that this is the mechanism of action. See, think about a disease. Disease is very complex, extremely complex. Okay, so you are predicting that this is the thing I should give to this patient. But then how do you know it is even working, if that is the thing? So then you have to confirm it, right? So that is where pharmacodynamic biomarker comes in it. So by measuring the functional consequences of a drug's interaction with this target, they can confirm that the drug is having the desired effect, what you want to do. If it is still not working, that means that may not be the main reason why the person has this disease. So that is why you have to maintain that thing. Suppose you are giving an anti-cancer drug, right? So what is the end result of anti-cancer cells? Cancer cells should die, right? So one of the way to measure cancer cells is that they are replicating. So there is a marker called Ki67. So if Ki67 levels decrease, that means drug is effective. Sometimes you cannot see the tumor shrinking right away, but if the drug Ki67 levels are going, you know your drug is working because proliferation is going down, right? So that is what it means, okay? So that is very important first in clinical trials to see whether the drug is actually working. And you can actually, based on PD biomarkers, you can improve efficacy. This is working, this is not working, what dose is working. You can make a lot of decisions there, and you can reduce toxicity and increase efficacy, okay? And PD biomarkers also help in understanding resistance. So resistance is one of the biggest thing in cancer. You give a drug, you are happy about it, but then cancer cells develop resistance. So initially it is working, later on it is not working. So in the last lecture of today, I will show you an actual graph. You will be so happy to see, oh my God, this biomarker is decreasing like this. And then you see, and it is increasing again. So now you know it has developed resistance, right? So PD biomarkers are very important, okay? So here I'm comparing predictive, prognostic, and pharmacodynamic biomarkers. So predict, identify patients which are likely to benefit from a specific therapy. Prognostic will tell you the outcome. We are making an outcome: pancreatic cancer, bad prognosis; breast cancer, good prognosis relatively. Pharmacodynamic will tell you the biological response to a therapy. See, look at this. Is it really hitting the target? That's what it is. Okay. So there is a comparison table: predictive, therapeutic, and pharmacodynamic biomarker. Predictive is before treatment because you're trying to decide what drug should be given, right? Therapeutic biomarker is during treatment, and this is shortly after drug exposure. Is Ki67 going down, right? This is more about, is it hitting the right target, okay? This will predict benefit and non-benefit before treatment for predictive. Which patients are going to be benefits? For example, it is HER2 cancer only, and you are giving Herceptin, it will be only affected for HER2 cancer, not for any other cancer, right? So that's what it is telling. It will help you in treatment selection. It will tell you whether they are going to be sensitive or resistant. So somebody has HER2, but you are giving a drug for BCR-ABL, it's not going to work, right? So you have to have the right patient for the right drug here, okay? So, so this is some examples: BRCA1, EGFR. If BRCA1 is intact, you are not going to target olaparib. You are not going to give PARP inhibitors because they're not going to respond to PARP inhibitors, right? So that's all covered under predictive. So therapeutic biomarker tells you, is the therapy working? If the therapy is not working, you could change the dose of the therapy, okay? So, and it will tell you PSA levels are going down, therapy is working in prostate cancer, okay? BCR-ABL is declining, Gleevec is working. If BCR levels are not declining, BCR-ABL is not working, okay? All right. Pharmacodynamic biomarker, like I said, Ki67 is a very good. Ki67 levels are going down, cancer cells are less and less, okay? If you are giving HDAC inhibitor, histone acetylation should increase. So that is all pharmacodynamic biomarker. So I will show you many case studies, and these are very interesting to see case studies, okay? So case study for diagnostic biomarker. So this is a prostate cancer case where it is PSA. We measure PSA levels. So the biomarker is PSA levels in serum. So in prostate cancer, PSA levels increase. So many people who are over 65 or 70 years of age, they undergo PSA test regularly, okay? Because many times, even before the cancer is actually visible or identified, if PSA levels are rising, they will immediately get it tested. Many times men have enlarged prostate, but they don't have cancer. So to make sure they don't have cancer, you measure PSA levels, okay? So that would be a diagnostic test. Elevated PSA levels suggest possible prostate cancer, okay? But it could also be elevated at a very initial stage before cancer actually develops, but it will give you a warning, some red signal, okay? So case example, a 65-year-old man, no symptoms, elevated PSA routine test, just the annual physical exam. Prostate biopsy confirms localized prostate adenocarcinoma. No symptom, no pain, nothing, just PSA levels told. What did you do? You do surgery, gone forever. Okay. Case study 2, HER2 expression in breast cancer. So remember, mammography is a part of the annual physical exam. So 48-year-old woman with palpable breast lump. So in mammography they will find if there is some lump there, and once they find, they looked at HER2 gene by FISH. You know, FISH will tell you if the gene is amplified, or protein expression by ISC. Do you guys know what is ISC? You know, immunohistochemistry. So you take the tissue sample, and when you are looking at the tissue, you see, you call it histo. If you are looking in a cell, you call it cellular, right? And so it is antibody based. You add the antibody, if the signal lights up, protein is there, right? So it's immunohistochemistry. So that's how this case HER2 positive breast cancer was identified. So see, the person just went for mammography and they found that this person has cancer. So biopsy confirms this thing. This was the score, HER2 positive. This, the patient receives Herceptin. Okay. Now case study 3 for diagnostic biomarker, pancreatic cancer. It doesn't show up. Okay, because there is no biomarker for stage 1, stage 2, stage 3, because it shows rarely any symptom there. So there is a big gap in our understanding about pancreatic cancer, because we don't have the biomarker to detect it at an early stage, because it doesn't even show any symptoms at that stage. So that's a very bad news, and that is why pancreatic cancer is the most lethal cancer, no doubt about it. But the good news is that very few patients get pancreatic cancer. Okay, that is the only good thing about it. Like lung cancer, huge number of people get lung cancer. Okay, so unspecific symptoms, there is no screening, there is no biomarker, early stage, you don't even have imaging thing. You can image it, but you don't know what you are looking for. So you can look at the pancreas, but then what is the abnormality we are looking at? So we don't even know what to look at, right? So there is a huge gap in biomarkers in pancreatic cancer, diagnostic biomarker. We cannot diagnose pancreatic cancer at early stages, right? And that makes this cancer lethal. Okay, so gaps in diagnosis. We don't have any, we don't know what exactly we are supposed to do to stop it, because we don't even know how to diagnose it. Forget about stop it. We don't even know whether this person has it or doesn't have it. Okay, now let's look at prognostic biomarker. P53 mutation in colorectal cancer. If somebody comes and tells you this person has P53 negative breast cancer or prostate cancer or whatever cancer, what would you think first? What is your first thought? So suppose somebody comes to you, that person A is diagnosed with this cancer and it is P53 negative. Huh? And if it is negative, then what is your prognosis? Bad.
It is relatively lesser bad.
Yeah, and it is completely gone. It's bad news, because tumor suppressor like P53 disappearing is not good news, right? So you can say, if somebody comes, this guy is HER2 positive breast cancer versus triple negative, you know triple negative is very hard to treat, your prognosis would be very bad for triple negative, right? If somebody says pancreatic cancer, pretty bad prognosis, right? So that's what prognostic biomarkers, we are predicting the outcome for that patient. Okay, so P53 gene mutations means aggressive tumor, right? So now we have to really closely monitor the patient. Okay, another case, HER2 in breast cancer. HER2 is overexpressed. So before we developed this drug Herceptin, you know what are the things I'm telling you? These are very recent discoveries, because it's the We have made tremendous progress in cancer biology in the last 20 years or so, maybe 30 years. So especially CAR T therapy and all these things, these are all, actually less than 5 years. So before that, it was just across the board: chemotherapy, radiation therapy, chemotherapy, surgery, radiation therapy. So it was pretty bad. So that's what it is saying. Before, this is the trade name for Herceptin. So before Herceptin era, HER2 positivity was poor prognostic marker. People used to die. It was highly fatal disease. But with Herceptin, prognosis has improved. Okay, so HER2 positive status alerts oncologists to more aggressive tumor biology. It is still better than triple negative breast cancer. Okay, and we have a very good drug, Herceptin, against HER2 positive one. Okay, so now let's go look at the case studies of predictive biomarkers. A 54-year-old woman presents with metastatic non-small cell lung cancer. A tumor biopsy performed, followed by immunohistochemistry and next generation sequencing. Now they are telling you, they are presenting you the whole case. You guys have enough background in cancer biology. I will ask for your prediction. Okay, so this one person has this thing here. So PD-L1 is expressed. Okay, tumor mutational burden low. Tumor mutational burden means that the tumors are undergoing mutations all the time, so that they survival of the fittest for that. Okay, EGFR is exon 19 deletion. So you don't know what is this. When EGFR, this, what are exons? Do you guys know what are exons? You don't know that. You don't know that. You guys don't know that either. Okay, even if one person doesn't know, it's the same thing whether two or one. Okay, so what happens is that in E. coli or any prokaryote, prokaryote and eukaryotes, right? So all prokaryotes, the DNA is there and the RNA is exactly like DNA. So if this is one gene, then the RNA will be made like this. Okay, and then RNA will make the protein. So suppose I go to RNA is identical to the DNA, but in eukaryotes that is not the case. So when RNA is made, it has different regions: exon, introns, exons, introns, exon, introns. So then all the introns are deleted and all the exons are ligated. That's the mature RNA. This process is called splicing. And then this mature RNA will make the protein. Is it making sense? So the DNA sequence will make the RNA with lots of introns. Introns are diluted, exons are ligated. So you would think, why nature has chosen such a mechanism? What is the advantage? The advantage is this, that this is the DNA sequence, right? And you make this huge RNA with a lot of introns. So in many cases, these introns are not ligated exactly at the same way. Now you have so many pieces, 1, 2, 3, 4, 5, 6, 7 exons. So these 7 exons in one tissue, remember every cell in our body has exactly the same DNA, but they have different RNAs. They have some housekeeping genes which are similar in every cell of our body, like glycolysis genes, right? Krebs cycle genes and things like that. But then they have unique genes also, because neurons are different from intestine, from skin. Liver cells have different function, neurons have different functions, so they obviously have different proteins. If they have different proteins, they have different RNA. So for example, so one DNA RNA is formed. Now let's say it has 7 exons. So these 7 exon containing RNA is spliced differently in the brain to make a different protein, but the same 7 exon RNA is spliced in a different pattern in thyroid, and here it will make a different protein. So you have the same DNA sequence, but they are 2 different proteins. So one such example is that there is one RNA in thyroid. It forms calcitonin, and calcitonin is involved in controlling calcium levels here. But the same RNA is spliced differently here, and it forms CGRP protein that is involved in pain signaling in migraine. Okay, so now nature has increased diversity at RNA level, right? So those are exons. Some exons are deleted, some exons are ligated, and the ordering can also change. So you can actually, but it is a very controlled process. It's not random at all. But the point is that from one DNA sequence you are making different one. So in this case, so this obviously has many exons because exon 19 is deleted. So what is the consequence of exon 19 deletion? This EGFR protein becomes very active. So EGFR is a receptor protein, okay, which has an internal domain. It is a kinase. So it's a huge protein. So imagine that the cell membrane is this one here. So this is the part which is outside the cell, and this is the part which is inside the cell. Okay, so this is one EGFR, this is another EGFR. It binds our ligands, and the ligand is common, so the two things come together. So these two domains come together, they phosphorylate each other, they become active. But by deleting that 19 exon, one piece of it, this is always active. It doesn't need EGF, so obviously it is a very bad news because it's super active. That's what positive is the result. KRAS, if it is hyperexpressed, that's a very bad news because it leads to cancer. But it is ALK, so this is wild type, it is not mutated, good news. KRAS is present in the cells, as long as it is not mutated, it's good news. ALK rearrangement negative, MET is a protein, is a kinase, it is not amplified, negative, good news. So these two, ALK is not negative, so we can predict, we cannot use ALK inhibitors because that is not even a problem. KRAS, MET amplification negative, of course we will not use MET inhibitors for this case. PD-L1 is expressed. Will you use immunotherapy? Of course we will use immunotherapy. So we know we have to use immunotherapy against PD-1, PD-L1. Okay, predicts, this is something we have not covered, but tumor mutational burden, if it is low, predicts weaker immunotherapy benefit. But still PD-L1 is very important and it is positive, so we will still use PD-L1. Okay. Exon 19 deletion, we definitely will use EGFR inhibitors, okay, because that is a major thing. KRAS wild type, if it is mutation, then EGFR therapy will not work. Absence will tell us which is absent, because here it is no mutation, it is wild type, we know EGFR therapy will work. So by looking at the biopsy results, now we have decided the drug. Makes sense? That is predictive biomarker, and you can see how important it is. Before starting, we are not giving chemotherapy, we are personalizing it for that one patient, right? All right. So this is the details of what I just told you, and this is worth going over. EGFR deleted means EGFR protein is very active because only a small portion which regulates EGFR is deleted, so it is super active, we will use EGFR inhibitor. PD-L1, of course we will use immunotherapy, okay. So we have decided, and we give this drug, and after 12 weeks the outcome is tumor has actually shrunk. Guess what, if some cancer patient hears that tumor has not, the tumor is stabilized, that itself is a cause for celebration, that it is not growing. That itself is a big cause for celebration. If tumor is shrinking, it's fantastic news after 12 weeks. Okay, so this is good. So basically we have predicted based on the biopsy results. Case study 2, Ki67 is a proliferation marker, remember? So high Ki67, bad tumor. Low, so high Ki67 indicates rapidly dividing cells, disease is aggressive. Patient receives closer follow-up. We have to really monitor this patient very, very closely. Okay, now let's go to pharmacodynamic biomarker. Case study 1, imatinib. This is Gleevec in CML. So a 48-year-old man with CML starts on imatinib, and then it is very easy. You can do PCR. So imatinib, what it does is that, so I had to check this thing, because if BCR protein is there and imatinib binds BCR protein and switches off the activity, right? So the protein activity is low. So why would you do PCR to look at PCR levels? Because when you guys all know PCR, right? PCR, you are looking at what levels? You are doing QRT-PCR basically. So you are making the RNA out of it, and you are measuring the RNA levels, that how much RNA is there, right? Transcription level. So if you are inhibiting the protein, why would you look at its transcription? And the reason is that in many cases, suppose I am inhibiting an enzyme, so the real test I would do is to isolate the enzyme and see if it is active or not active, right? Why would I look at the mRNA level? I am not touching the mRNA level, but in the case of BCR-ABL, it is slightly different. If BCR-ABL is inhibited, then BCR transcription goes down, and the reason its transcription goes down, it's like BCR-ABL is standing here, and it turns on the pathway so that it is produced more. So it activates the signaling to make more of itself by a transcription. So that is why BCR-ABL is inhibited, even the levels go down, because the transcription of BCR-ABL goes down. That's why you can do a quick PCR. How easy it is to do PCR? 10 minutes, 1 hour later, you know it, right? When COVID was at a rise, people were doing COVID-based tests, right, by PCR. They would take a swab, and 2 hours later you had the result, whether you have it or you don't have it, right? So, so you do QRT-PCR there, right? And that will tell you. So in 3 months, BCR-ABL transcripts drop by more than 90%. You know, so pharmacodynamic biomarker said disease is really, really working, right? Okay, take-home message in biomarkers. Biomarkers are measurable indicators of biological process. Again, I'm just showing you 4 here, but there are more than 4. Right? So now you can understand how important are these biomarkers of cancer, and they can really help you with the right therapy and everything. Okay, so what are the challenges? We still don't have reliable biomarkers for many cancers. Pancreatic cancer is one of them. And the biomarker needs to be very specific, because if it is non-specific, it is a useless thing, right? You have to have. So we have to integrate genomics, proteomics, metabolomics, and when you are, when you have to measure the biopsy, if something is at the surface, it is easy to biopsy, but if it is an internal organ, you don't want to go there and do a surgery to take it out. So many times what happens that its tumor cells shed something in the bloodstream, and you can just withdraw blood and you can see if those markers are there. Try to make it as less invasive as possible, not to stress the patient. Okay, so that biomarkers can really help us make the right clinical decision to treat that patient. Okay, wow, good. So let's start the third one till we are given the signal to stop. Okay.